All right, here we are. Welcome to another Compliance Capers. My name is Sonal Patel with SP Collaborative, and I'm joined by my very good friend, Betty Hovey with CHCS Consulting. Hi, Betty. I'm
Hello.
sorry, I flubbered that name. I'm sorry.
That's all right, Sonal. Hey, how's everybody doing? Glad to be back again to hit another discussion on TPE.
That's right. Yeah, we're trying to power through our month of June, hammering home the fact that our Medicare administrative contractors, those MACs, are actually working hard and releasing a variety of active targeted probe and educate audits. I know at the beginning of this month, I hope all of you have tuned in or watched the replays on the background information episode that we started the month off with, because that episode is rich with the details of this complex program. Definitely complex because there are multiple rounds involved, multiple deadlines that our providers and practices and entities have to meet, and then submit their documentation and pass. And like I've said again and again in every episode, it doesn't matter. We don't care when you pass. You pass in one round, round two, round three. It doesn't matter. It's a win. And last week we talked about a specific Novitas evaluation and management TPE audit that is going on for both of those jurisdictions, JH and JL. So if you're in the Texas region, and if you're in the Washington, D.C. region as well, both of those jurisdictions are being affected. But for today's conversation, again, I wanted to highlight yet another one of those active items on the list for Novitas. And that is going to be an active item for our psychotherapy types of services. And I know you and I have spoken, cannot remember which month we talked about psychotherapy in, but we talked about it quite a bit, especially for this code set for the psychotherapy space.
Yes.
And these codes that we talked about earlier are being talked about again here in this TPE. Because our psychotherapy is unique. It's going to be time-based. And of course, anything time-based when it comes to the CMS is going to be looked at critically with a fine-tooth comb on making sure that those time requirements are actually being met.
Yeah.
So, yeah.
Yeah, those are easy ones to check on from a compliance and documentation standpoint. Is the time there or isn't it? And then adding the time up, does it make sense for how long your practice is open for and how many patients you're seeing in a day? It's not hard to do the math there. So yeah, they check on those.
That's right. That's where we spoke about it. We spoke about that Connecticut psychologist or psychiatrist that got caught up in not being in the country or taking a vacation or whatever.
Yeah.
That's right. We spoke about it then with some
Doing like
enforcement
100
issue.
hours and
Yes,
like
that's right. That's right. That is correct. Yeah, so that's one of those no-nos. So hopefully these TPEs are just meant for those folks for educational purposes, right? They're not going out to the blatant fraudsters that we also do talk about on compliance capers from time to time.
Yes.
But yeah, it's a good idea to start implementing better processes, especially in your compliance program. Tweak it to make sure that you're documenting how and when you're receiving education from consultants, from compliance folks, from your attorneys that might come in from time to time, whomever. Document the fact that you did embrace that education that you received on site or via a Zoom recording, however, but that you now understand how you need to tweak your EMR. Perhaps your EMR was not adequately, capturing your time in and time out. Things like that. There are numerous ways to ensure that the time you are spending with your psychiatric patients, that time needs to be documented appropriately. So that service, that particular CPT code that you're sending out is going to match that coordinating documentation on the back end. Because like we said in previous episodes, and I think you said it so well, is that they will receive those claims and understand, absolutely, you saw that patient for that 90837. You saw that patient in crisis. The diagnosis code matches that CPT code for the 60 minutes, right? It makes sense. Sure, you saw the patient for 60 minutes for that psychiatric disorder, but that documentation on the back end, when they ask for it, needs to reflect what you sent out on that claim form.
Yep.
So, yeah. So this is that checklist of those around 9 or so active items, and psychotherapy is definitely one of them. And that's what we're talking about here today. Novitas also provides a wonderful checklist of what sorts of documentation requirements are going to be necessary in this TPE type of situation that you're under. And they've provided a specific checklist for that purpose. So not just a checklist for psychotherapy services, it goes in even deeper for a checklist for what you need to send in for those services based on this TPE.
Right.
So Betty, I'd love to hear you talk to the audience about what those specific details are on this checklist.
Well, just like last week when we were talking about the E&M TPE, some of the stuff is the same, because it's just applicable everywhere. Like they tell you, make sure it's the correct person, make sure there is a valid and legible signature, make sure, that your date of service is correct. So, some of those things are just, you're going to do no matter what they're asking you for. But then, because of the psychotherapy issue, where you sometimes have other types of practitioners doing the services, and that was actually one of the denials and one of the errors they were finding was that the person that was giving the service wasn't in their scope of practice to be doing the service. So something here that they ask for is documentation clearly identifies the person performing the service, including their title, their education background, and their credentials. So they're very specific at what they're looking for there because of that issue that they were finding with the records they're looking at, and that the documentation clearly demonstrates session start and stop times and or total time spent providing psychotherapy services to the beneficiary. Because they're time-based codes, y'all also, if you do these kind of services, y'all will want to check with, different payors and different MACs in different areas. They may require start and stop time versus a total time. So definitely kind of check and see what the requirements are to make sure you're meeting them. Here they don't care. They're stating it either has to be start and stop or total time. Documentation demonstrates the type of service. The telehealth method. So because these services can be done and are covered under by telehealth, it's also asking, make sure you're stating if it's done telehealth, is it audio, is it audio visual, what type of service is being done here with the patient if it's being done virtually. And then the type of service being provided, because one of the guidelines with documentation for psychotherapy is that the note should contain a description of at least one of the techniques that were used in psychotherapy with the patient. There's mainly insight-oriented, behavior modifying, and suppurative are the three main types that they use. So they're saying in the documentation, it should state at least one of those techniques that was used. So it should say, patient DBT was used with this patient to help them deal with blah, 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 whatever their problem is. So that's giving a behavior modifying thing, or whatever it might be. But this is saying that needs to be in the note to help support the fact that psychotherapy was actually given to the patient. And then it says it should support the medical necessity for psychotherapy. So they want to see that the maladaptive behavior, whatever it was, that supports the need for ongoing psychotherapy treatment, the results of any clinical tests that were performed, medication, prescription, and monitoring, if it's applicable, summary of the diagnoses, the symptoms, the functional status, and the treatment plan for the patient, and the frequency of treatment furnished, prognosis, and progress. So if the patient is being seen weekly, to see that, the note is saying because the patient still remains a bit unstable, weekly sessions are still required medically, blah, 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 something like that, to where it's stating to them that the frequency that the patient is being seen is still medically necessary, therefore, supported. And then incident 2, again, is coming up again, documentation to support the incident 2 guidelines if applicable, including evidence of the billing provider's presence in the office suite and ongoing participation in patient care, as we talked about last week with E&M. And then if the services have an E&M component, because in this TPE, we said they're targeting 90832, 34, and 37. And those are the psychotherapy only codes. The 90832 is for 30 minutes. The 90834 is for 45, and the 90837 is for 60. But each one of those has kind of like a secondary code that is psychotherapy with an E&M. So if that is mentioned in there and it's dropping into one of those other ones, they want to make sure that if there is an E&M component in there, that the E&M service is going to be documented enough to where it supports whatever level you're billing out. And then if applicable and required, submitted documentation should include the beneficiary's waiver of liability. So those were the checklist items on this one. And again, on that link Stonewall gave y'all, it's just a one-page little checklist. So like we were talking about again last time too, not something that would be a bad idea, to do as you're getting the records together to send to the payor, to make sure you've done everything that they're required, the ones that are applicable to that record, and then send it along with the record to say, yep, completed this in full for you. Everything's here, making your job easy. We've got everything in a bow for you.
That's right, Betty. That's an excellent breakdown, in my opinion, when I was listening to you talk, not only for the time, but for all of the supporting and supplementary documentation, right? That goes with these types of psychotherapy codes. There's only 3 that they're highlighting here, but there's a vast array of supportive documentation that this particular MAC is going to be asking for. So I'm glad you highlighted that and put a big spotlight on that for the audience, because you and I have worked with enough providers in our many years that if they're doing this on their own, that supportive documentation is always missed, right? And then when you and I step in, we come in right away and identify, well, where is all of this other supportive information, right? Because we are the ones that are well aware of what the CPT code definition is, and then all of those subsequent definitions and requirements and details that are needed for that additional documentation that we know is somewhere in the EMR. It's just a matter of us finding it and then instructing the office and their admin to please print those so we can help you organize it in such a fashion to then present this packet for the TPE process, right? Submit it in a rational format for the MAC to understand. This is our entire packet in a very easy, smooth way for them to see that we followed their checklist, and we're just providing them with everything that they requested in a very easy to read fashion. So then they don't have to also jumble through the EMR like the office admin and like you and I have to do all the time, jumbling through the various types of documentation that is necessary to meet the multiple hoops that you have to jump through in the TPE. So yeah, really, really good. And I, for one, always love to advise my providers who use time-based codes. It's really a good idea to do that time in and time out, right? I know in this particular Max case, it's not a requirement. They said you could also do that lump of time. But I always think it just looks better. It reads better, that time in and time out. It's just so much more accurate, right? It doesn't always have to fall in a round number. It doesn't have to be, well, I saw the patient for 60 minutes. How often is that the case, really, right? It's really going to be 58 minutes or,
Right.
an hour and 3 minutes, right? To be fair. So that's just my two cents there. But yeah, I think this was a really interesting checklist because it does go into all of that extra supportive information, different than that extra supportive information that we heard from you in last week's E&M discussion of the progress notes and the orders and all of that type of supportive information as well. So, yeah. Do we know what round we're in? I think we're in rounds 1 and 2 for this particular TPE audit, I believe, for psychotherapy. Let me pull up that link when I find it here. I think it's this one, our last link. For that wonderful bar graph chart that they provide us with the details of where they're at, what is their status, right, in this psychiatric services TPE, their round results, as
on some of them,
they say.
And looking at it, and that's also where they give those top denial reasons, which, we'll go through in a minute. But as far as the rounds go, it looks like most of them are still in round 1. There's a couple that are in round 2, but that's it. So they're actively working through the rounds in here. And when you look at them, I don't know why, like one of them, the round 1, well, this is a good thing. Round 1 was December 2021 through July of 2022. And then there's no round 2 or round 3, which, means that, they did very well.
They did well.
So,
yes.
They didn't have to go any
That's
more
great.
rounds.
So they passed. Excellent.
Yes. So we'll show you percentages and, sometimes it makes sense. You'll see them, progressing, like one of them that did have 2 rounds. They had 71% minor issues in the first round and 75% minor issues in the second round. So, so the moderate issues they had moved down to minor. So that again is a positive thing. So that means they're getting better. Any of the things they have are little bitty things or tweaks, like we like to call them.
Exactly.
But I was confused because these, and when you look at them, they're just graphs. They don't have names, so we don't know who they're talking about, where they're talking about. And I don't know, when I pulled that up, it probably totally, you probably like, what is she pulling up there? But
it's just a white piece of paper. Yeah.
They're just very non-specific. It doesn't even have region or anything like that, other than what the state is, kind of thing. But it'll show you the rounds. And the other one that has had 2 rounds, and this is where I was, and I don't know, I'm just confused in general by it. Their round 1, they had 63% minor issues, 6% moderate, and 31 major. In this second round, They went down to 33% minor, no moderate, but now they've got 67% major issues. So whatever they got educated on in the first round, somebody didn't understand it.
Yeah.
Or when you look at the denial reasons, it might be where it got ignored in the second round, like something didn't get to them like it should have. They didn't get all the notes in. And so again, if you don't send us what we're looking for, it's an automatic no. Because in one of the denial reasons, and I always hate this denial reason because there's just no excuse for it, was there was no response to the additional documentation request. When we asked you for records, you didn't send us anything. So if you send nothing, you get nothing. You get a big fat goose egg as your result, which is not good. So maybe they only sent part of the records and something was missing and they didn't send the rest like they needed to. And so they just got failed on all of those. I mean, I don't know, but to go from 73% of minor to 75% major, that's a big swing. So something happened. But so you can kind of look and see, but some of them are now getting into their round twos, and so we're looking at progressing through it. But yeah, I think the denial reasons are things that you'll want to kind of cover through here on what they were looking for with the psychotherapy ones.
Yeah, no, but that's a great breakdown of these interesting but deliberately vague charts that we've provided for you on these links, right? It is interesting the way CMS has access to the data. They're telling us that they're analyzing everything, but they have to be deliberately vague, right? And produce these copious amounts of these bar graph charts. You could not see it when you pulled it up. For the audience, it was just a white sheet of paper, but these are bar graphs that are in green, that are in like a bright green color, that identify the areas of weakness, right? Minor to major. So we like to see very minor, right? In a very high percentage. So tons of stuff that was in the minor things that we just needed a tweak. Things that are major, like Betty was stating, had escalated, like that practice went the wrong way. Right. And we're just hypothesizing because these charts do not provide any detail on any practice. It is just a vague bar graph. That's all it is. But that's a great point that I wanted to circle back on that you made, that area of deficiency highlighted in this psychiatry TPE is that no documentation was submitted. And we've talked about that time and time again on compliance capers. It drives us bananas because, again, we have to start getting someone on the team, at the practice, at the entity to be the point person to handle these sensitive types of mailings from the CMS. That person has to be in charge. He or she can be the boss on that mailing that comes in from CMS. And then they can open that piece of mailing and then escalate it where it needs to go. Instead of just, again, I've said this on compliance capers, I'll say it again. People cannot squirrel the envelope away into their purse, into their pocketbook, in a desk drawer, on a dusty shelf. Like, no. It has to be dealt with, right? It's the CMS. It's not going to go away. It's not going away. And hey, if it goes away, guess where it's going to go? It's going to get you kicked over, right? Eventually, you will be kicked over because they will be fed up and say, we tried asking, we asked so we could help you, and you failed. And so now we have no choice but to kick you over. I know I'm on a rant here, but that was a really great point that this particular psychiatric TPE is stressing on what went wrong. But the other top denial or partial denial reasons that they've listed out are, again, for medical necessity. So the documentation that was submitted for review was lacking evidence of medical necessity for the following reasons. Number one, they say it was lacking that the practitioner was performing the service within their scope of practice. Again, like you highlighted earlier, great pro tip, just start including a signature block for them in documentation, right? Comma, who they are, right? What is their credential? That's a great pro tip. So then the auditor on the payer side knows who that practitioner is. And then number two, it says that documentation was lacking evidence to support the service as medically reasonable and necessary psychotherapy service. So again, all of that supplementary supportive documentation was missing. And then also third, documentation was lacking evidence to support the amount of time spent performing psychotherapy service. And again, I haven't really seen that too often because my psychotherapists are very good at capturing time. So I'm not sure what that means, but it could have a lot to do with their EMR system as well. It's just not structured to function properly to capture that time in and time out, because I've seen many EMR do that really, really well for these types of practitioners. So that's just my hypothesis there, that it could be that EMR system.
Yeah.
Yeah. And then they talk about, of course, incorrect coding. They put that as a whole bucket as well, which of course, as the coders in the audience will love, is that it says that the documentation submitted for review did not support the accurate number of units billed based on time spent in performing service, and therefore was recoded to the appropriate level of service based on time. So again, they're not paying you, but they will down code you, right, as appropriate, because the coder specialist, whoever coded it on the claim, didn't quite calculate the units appropriately. So we have to keep that in mind as well with time-based codes. And how do we do that? And our CPT books are very good in spelling out how to do those multiple units. And I know you and I have talked about that on some other compliance capers that was specific to psychiatric services. But so a lot of good teachable moments in these documents that are provided by this particular MAC jurisdiction for this particular TPE.
Now, I just wanted to on the time issue where I would see it is when they started doing the approximation, which is why I pushed that so hard. Is that the documentation, instead of start and stop times, it would say I spent approximately 45 minutes with the patient. Well, approximately 45 minutes doesn't cut it, because approximately 45 could be 40, which means you don't get your 90834, you get downcoded to 90832. So, you have to make sure that if you are not using start and stop and you're going to state a total time, that you state a specific total time and not do about, around, approximately, that you just call it and give it a time,
Exactly.
so that's usually where I see that happen, is because they do that estimation, which doesn't serve them well when it hitting right around what a code time is. They think they're okay, but it's not. It's pushing them back down.
That's a great point. Now, in the records I've audited in my years on psychiatric services, I have not seen that, but that's a great point, that if your providers are in that very bad habit in this psychotherapy space and choosing vague terms like approximately, we need to put a kibosh on that immediately. And start documenting. I spent 1 hour and 10 minutes with the patient. If you want to use total time, do it. If you want to state I spent 49 minutes with the patient, do it. That's much more accurate, what you did with that patient and for how long, rather than approximately, because you don't want to give any wiggle room to round up or round down your time. It needs to be accurate and definite time. So that's a great point that you've had based on experience. So that's perfect.
Yeah, the one of the ones I had that was doing that, unfortunately, had to do a payback because of it, because he wasn't in a TPE, he was in a full out audit, and they did not like the approximately time. So, yeah, please don't
Please,
approximate
please.
your times. Either start and stop or pick a time and stick with it.
Mhm. Exactly, exactly. And again, like you hinted at earlier in the conversation, do not escalate your services beyond the workday either. If you're picking
Yeah.
a time and sticking with it, like you just stated, please don't balloon that out when whoever comes back to calculate your total day at the end of the day. Make sure your total day is a business day,
Yeah.
right? And you're not extending your billable hours to,
Yes.
more than 9 to 4 or nine to
Yeah.
five or however long your psychiatric office is actually open for.
Yeah.
Please, we
They'll check on
implore
that
you.
stuff too. Yeah.
They
Yeah.
will
I mean, everybody
eventually check on
knows.
that.
It'll happen once in a while where, yes, the clinic's closed, but you have a
Yeah.
patient that really is in need and you're going over.
Oh,
Yeah,
absolutely. That
we
makes
know that it's
sense.
not going to be
Yes.
perfectly exact, but
Right.
if it's like those way over kind of things, I've had them where they come in and they inquire about, here are the stated hours of the clinic, and here are,
Mhm.
I mean, they do all those calculations. If they think there's something sneaky going on, they will do and get into that nitty gritty kind of detail with stuff. So for those people that are like, oh, nobody check, they check on all
They
that
check.
stuff. So, which is why incident 2, can get you looked at, just
Yeah.
because if they
Right.
see that one physician seems to be sending in claims for, over the amounts of time and that kind of thing, that it might kind of prick up somebody's ears because it looks funny. But when they look and see that some of that is incident 2, so they actually weren't personally performing all of those services, then but it can get you on the radar just because it, sets off the little ticker to say, ooh, something's weird here,
Mhm.
so just make sure everything or anything, as long as it's documented and it's indicating why it might look like there's an outlier situation, that's not what it is, that there's some explainable reason for why it's happening. So just document, make sure everything's documented correctly, because that's all y'all have to fall back on if anybody's looking at your stuff, especially if they're going, from 2 years ago or 3 years ago, that they're looking for something. You can't sit there and say, after how many patients have been seen in that practice in the past 3 years, that, oh yeah, I remember John Smith from Tuesday on October 4th of 2020, and I remember what we talked about. No, nobody's gonna believe that. So it's got to be all in documentation. You got to put it in there and got to get it in there right. Cover yourself.
That's right, Betty. That's well said. Yeah, our providers have to do a better job of CYAing, right?
Yeah.
Absolutely. Because they can't walk me through their day if it's 3 years ago,
Yep.
right?
I'm
Not
sorry, I went on
many.
a tangent too, so I
That's
apologize.
okay. That's okay.
I was like,
No, we're very passionate about our providers. We're provider advocates.
Yes,
So
that's
yeah.
true. You start talking, you're just like, and then, so yes, we're doing our
No,
own
no.
psychotherapy now.
We do our own. Yes. Don't you see my Lucy for 5 cents can out? It's right here, at the corner of my desk. Just pay me 5 cents.
The doctor is in.
Okay, we digress
All
again,
right.
but we always need Friday laughter, in my opinion. Always need a dose of laughter. But, I think it's a really good thing to continue to remind our providers to CYA, right? And that's what this documentation is for.
Yeah.
It helps it helps to defend you later if you're ever in a sticky situation. We are well aware that there are many and many and many emergent psychiatric situation that does not fall nicely or neatly into a 9 to 5 day. We're well aware of that, right? Patients in crises come in at any time.
Yeah.
And so long that encounter is well documented, you have nothing to worry about. There's nothing to sweat over. Because you happen to be a psychiatrist, these are the types of patients that you will be seeing from time to time in your career, right?
Yeah.
The pandemic proved it swimmingly. Many a patient came in for a crisis at any time, night or day. But it's just a matter of making sure that you document what you did at that encounter, and close it out and sign it appropriately. Because when the CMS comes back to request these types of documentation to help support your billed claims, it has to match up. And of course, the pandemic allowed for all of these types of services specifically to be captured via audio and video. So in the telehealth space, right? So we have to be able to make sure and implore that our providers are documenting that service appropriately, right? That you're using a HIPAA compliant technology platform, because now the days are over. We can't just be using our Skype and our Facebook and our whatever platforms that we could use under the waiver during the pandemic. Right now, we have to actually go out and buy, Zoom for business health. We have to go out and buy Skype for business. We have to go out and purchase these things like Doxy.me. We have to invest. We have to invest in this platform, right? And so all of those ducks have to be in a row as well, from CMS's standpoint now, currently post-pandemic. So I thought this Novitas region really spelled it out nicely in their TPE checklist, their chart results, all of their expectations that they have for this provider population. And I think it's really good, even if you're not a provider in this realm of TPEs. It's good if you're a provider who is a psychiatrist in this space to, start creating these types of checklists for yourself to make sure that your documentation is actually matching what this particular MAC wants. Because in general, the CMS is pretty much the same from region to region, although they will be more specific on other supportive documentation requirements they need from jurisdiction to jurisdiction. I know you and I went through some appendices a couple months ago on compliance capers where we told you, nope, this is a different rationale from this particular MAC. They don't actually want that, but they do want it over there. So it's really, really important that you embrace whatever region you're in, and take a look closely at that MAC's webpage and see what their expectations are for you, that provider in their region. Because I think this one for Novitas did a great job that can help so many providers out in terms of making sure that coordinating documentation matches all those claims that they're pushing out the door.
Yep. Yeah. Agreed. Yeah. I think Novitas does a good job. So it's a good one for people to go check your own MACs out, and see what's under their TPE stuff and what comments they're making, how people in your region are doing specifically on these open topics that are under TPE now, so that you can see if, how their stuff varies or what specifically they're looking for.
Exactly. I love it. That's a great piece of advice there at the end, my friend. Have we missed anything on this hot TPE topic on psychiatric services? I think we talked about everything that we wanted to, and it was a lot. So I hope our audience agrees and can take this back to their practices, their entities, their providers, and make sure that they get their ducks in a row, and just protect themselves at the practice and make sure the documentation supports those coded claims that are going out to the payer.
Yes.
Yeah.
Again, it's not about getting paid. It's about keeping it. So
that's right.
You have to document right to keep it.
Absolutely. Document right to keep your reimbursement. Absolutely. That's great, Debbie. All right, my friend. Well, we've got one more episode left to unveil to our audience at the end of the month. I'm excited about that. And that episode is going to happen to fall on my birthday, I believe, that Friday at the end of the month. So I'm excited.
Yeah.
Thought I could take the day off, but apparently I cannot do that just because it's a birthday, right? Those days are
I
gone.
know those days are gone. I know people are like, "Oh, happy I'm like, it's just another day
It's
anymore."
just another day.
Unless it's on the weekend.
That's right. Otherwise, it's just another day. That's
Yep, yep.
correct. All right, my friend. Well, I will see you next time on Compliance Capers. Thanks
Sounds
so
good.
much.
Thanks, y'all. See y'all next time.
Bye-bye.